Every day and throughout the world, people are at risk from different viruses. One of the most severely pathogenic, yet largely underestimated, is influenza.
This winter, we had a really intensive influenza epidemic all over Europe. And here in Germany, we had more than 50,000 new cases a week. And altogether, we had 1,800 deaths directly related to influenza.
Influenza viruses are unpredictable and easily spread. Following contact with anyone carrying the virus, the chances of catching it are over 50%, which is potentially lethal for the elderly or anyone with a chronic respiratory disease.
I think it may be a growing concern in the Western world due to the aging society, because we have more vulnerable people, we have more people with cardiovascular comorbidities, and they have an increased risk to die from influenza-related stroke or myocardial infarction.
We know that 20 to 30% of patients with influenza that need hospitalization have a secondary bacterial infection. And this is due to the damage of the epithelium, the respiratory epithelium caused by the viruses, by influenza virus. And then the microbes that are colonizing the oropharynx, or in cases with chronic respiratory diseases, the upper airways, they can cause secondary bacterial pneumonia, which is very lethal and with a high morbidity and mortality.
I think the burden of influenza is largely underestimated because a lot of indirect effects of influenza that are deadly are not really associated with influenza when it comes to public health reports. When it comes to the death certificate of patients who died from influenza, and they died, let's say, 1 week later or 10 days later due to myocardial infarction or stroke, then usually the doctor who is signing this death certificate does not really relate to the influenza as the underlying cause.
Asthma is a Th2 disease, and a little bit surprisingly, the same immunological mechanism takes place in pregnant women, making them more susceptible for flu disease. It's also a risk for the unborn child.
There's little doubt that societal changes have helped to increase the speed of the influenza virus throughout the world and increase the prospect of a pandemic.
Normally, influenza is spread from the southern hemisphere to the northern hemisphere by birds, and vice versa. But now there is a discussion about human transmission, and the main reason for this is the increase of global traveling. A very interesting paper had been published recently in which they investigated people on planes and the movement of peoples in planes, and what they were able to show is if you are sitting beside someone who is infected by a virus, your likelihood to get it is 90%. And this drops down to people sitting 5 lanes behind the infected ones to 10%.
The contagious nature of the influenza virus means that those most at risk can be affected by numerous sources, including children and grandchildren.
In Japan, after a severe flu season in the early 60s, they implemented a mandatory vaccination program for children. And we had, similar to the pneumococcal vaccine, nice herd protection effects, because as long as this program was in place, the mortality, the influenza-related mortality in patients over 65 years was decreasing. And then in the late 80s, they stopped this mandatory vaccination program for political reasons. And after this, the mortality, the influenza-related mortality in the elderly went up again. So children vaccination programs may be very effective in regard of herd protection. And on the other hand, we've seen it in this flu season. Influenza B, for instance, primarily infects younger patients and children. And children up to 4 years have also an increased burden of influenza-related deaths. So you protect the little children, you prevent the transmission to the grandparents, and you decrease the mortality in both extremes of age.
There are, of course, well-known treatments available for influenza. But to what extent are they effective?
The problem of influenza virus is that this is a kind of virus which is changing its surface shape from year to year. So it's a little bit different every year, which makes it difficult to find a common treatment for this pathogen. There are treatments available. The most prominent ones are so-called neuraminidase inhibitors. The problem with the neuraminidase inhibitors is that they are only affected in between the first 36 hours after being infected. In the first 36 hours when there is a dramatic virus replication. 95% of the patients cannot be treated in time.
I think vaccine is always the best approach. But the problem with the vaccine is that particularly the elderly, who bear the highest burden of the disease, show a very weak immunogenic response to the vaccine. So this is a problem. So despite the vaccine, we will always have patients to treat. So I think from my point of view, it would be also nice to increase the kind of companion diagnostics. So if you have point-of-care tests in the doctor's office, for instance, and nowadays you can do this with isothermal PCR, you get a PCR result in 20 minutes for a reasonable price, then we can get this drug to the patient very quickly, and then we see a better effect.
The WHO states that influenza vaccines are safe and the principal measure for preventing influenza. And yet, of the vaccination target groups in Europe, only 44% are actually vaccinated.
Vaccination is the preventive measure to drop down the influenza rate. However, very unfortunately, people do not do this. There may be several reasons why it is not popular. So one is the spread of social media. You every time find someone who has a negative experience with vaccination. There is severe complication rate of influenza infection. About 1 of 3 million people vaccinated shows a severe complication, mainly narcolepsy. However, the benefit risk ratio is much on the sides of benefit for vaccination.
We have evidence for the relationship between influenza and cardiovascular events from epidemiological studies. But we have also nicely fitting studies showing that the influenza vaccine can actually decrease the risk of stroke and myocardial infarction. There are meta-analyses published, and there are even randomized controlled trials. And I was surprised because there are very good trials, 15 years old, showing that the influenza vaccine for secondary prevention of cardiovascular events in patients who survived stroke and myocardial infarction is as effective as, for instance, smoking cessation or statins or antihypertensive drugs.
In 2018, the WHO recommended trivalent influenza vaccine as opposed to the more expensive quadrivalent vaccine. While it helped health budgets in the short term, was it the right choice?
In this year, this was a disaster because if you take the burden of morbidity and mortality into account, the costs for treating influenza people had been so high, so you could use the quadrivalent vaccine 10 years to be as costly as the disease burden had been. So I think there will be a tendency to change the recommendations and to use the best available vaccine independently of cost considerations in the future. This has been decided in Germany, and I'm sure this will be decided by other countries in Europe in the same way. However, I have to point out that the efficiency of the vaccine is still not the best, and we need a lot of research and a lot of development to make influenza vaccines better.
Clearly, there's a lot of work that needs to be done to protect the general population, but especially the elderly and anyone with a chronic respiratory disease.
We have a vaccine that is not really perfect, but we know that it works. Particularly during the last 2 years, we had a lot of very nice point-of-care tests that help us to see if this patient has really influenza or just the other respiratory disease. I think this is very important, and we need to speed up the treatment of cases with confirmed influenza. On the other hand, when we increase, for instance, the vaccination rates in children that are the super spreaders, this is also very effective. So we have a lot of tools, we have a lot of strategies. They are all, I think, when we all combine them, we may be very effective in reducing the burden of influenza. But the most barriers I see now not in the research, except for the universal influenza vaccine. This would really be a breakthrough. The most barriers I see actually in the healthcare setting.
I think that they have to be sensitized for vaccination and to insist vaccination to especially elderly population and patients with comorbidities. That's very important. It's the main way, and might be to fight for a rapid detection of the virus.
If you are a staff member in a hospital, staff member in the healthcare system, you are very likely to get the disease, but you are also likely to spread it to patients. And these are patients, so the one who are mainly at risk for severe course of the disease. We, as a hospital, Hanover University, we offer influenza vaccination to all our staff members. However, this year the vaccination rate has been 29%, which is lower than the vaccination rate in the general population. This is absolutely disappointing. And I think this is lack of knowledge in two circumstances. Knowledge about the severity of the disease and the risks which are personally in between being infected, but also the lack of knowledge in terms of the consequences for others if you are an influenza infected patient. So we have to address the social responsibility and your input into prevention, not only for yourself but for others, more into our advertising campaigns.